This journal we will be discussing invasive cervical resorption, a case report, and review of literature. Root resorption is the destruction and disintegration of the root structure of the tooth due to an autoimmune response resulting into the host tissue cells attacking a part of the tooth structure. There are two types of root resorption: internal root resorption, otherwise known as pink tooth of mummery, and external root resorption.
Identify internal root resorption. It is also known as the pink tooth of mummery, wherein it is a type of pulp disease which is characterized by loss of dentine as a result of action of the osteoclastic cells stimulated by the inflammation of the pulp. Sometimes it is caused by a dental infection within the tooth, wherein it is located in the pulp itself. That's why it will be enlarged and it will appear pink.
External root resorption is a process that occurs in both vital and non-vital teeth, in which there is an irreversible loss of dentin, cementum, and bone. It can be either physiologic, in which it is a desirable process, usually occurring in primary teeth, resulting in the exfoliation of deciduous teeth, whereas it's pathological when there are several factors that include orthodontic therapy, trauma, periapical or periodontal inflammation, tumors, cysts, occlusal stress, impacted in supernumerary teeth, and transplantation, as well as other systemic factors such as Paget's disease and renal and hepatic disease, along with endocrine imbalance. Our focus would be on cervical external root resorption, otherwise known as invasive cervical resorption, due to its invasive and aggressive nature on the dental tissues. It is mainly pathological, yet there is no known etiology of this pathology. However, the only difference between cervical external root resorption and inflammatory type root resorption is the formation of necrotic pulp tissues and pulpal involvement. It usually occurs below the epithelial attachment and is not always cervical but along the pocket midline.
This case report involves a successful treatment in an 80-year-old medically compromised low-risk female patient with a complicated medical history, thus having a good oral hygiene. The patient in this case had a medical history of atrial flutter, hypertension, edema, and renal disease. Hence, the patient was classified as an ASA Class 3 patient since the patient was stable and was not a high-risk patient.
These images show where the cervical resorption is located. Clinically, it is located 2 millimeters mid-buccal above the marginal gingiva and extended below the marginal gingiva. A pink spot is found right below the cervical region of the tooth as a result of the resorption of the enamel and dentin, leading to the seepage of the highly vascular granulation tissue into the effect. In the preoperative radiograph, it is shown that there is a failed root canal therapy treatment, and it fails to depict any pathology on the tooth. However, upon probing, the extent of the resorption could not be judged.
At the surgery appointment, after the informed consent was obtained, the site with respect to tooth numbers 42 and 43 was injected with 2% xylocaine epinephrine via local infiltration. Here is a picture of post-flap reflection. As you can see, the root resorption extended subgingivally and hence, a gingival flap was needed for access. Using a 15C blade, a circular incision was made from the initial of tooth number 42 to 6 mm distal to tooth number 43 on the buccal and lingual aspect. The flap was then reflected using a periodontal elevator, and the defect was exposed. The patient had a pacemaker implanted last 2002. This recommended to advocate the use of hand instruments in such patients and keep the working area safe from any electronic cues. That's why they used hand instruments for debriding the periodontal region, and the light composite curing unit was assumed to be safe. A light cured glass ionomer cement was then placed into the defect, and the defect was sealed. The gingival flap was then repositioned, and the flap was sutured with silk interrupted sutures. The patient was then evaluated 6 months later, during which the resorption seemed stable and the defect did not increase. Hence, the patient was placed on a 3-month periodontal maintenance from that visit onwards. Here is a picture of before and after the successful cervical external root resorption treatment. As we can see, after 6 months, there is no more progression of the invasive cervical resorption, thus it seemed to be stable.
So in conclusion, the successful external root resorption therapy has to have a good case selection, early diagnosis, and good prognosis. The case was excellent in selection because the patient is geriatric, and due to her advancing age, she has many health problems, which gave a really good prognosis for her to undergo treatment. Here we have our case presentation for our periodontic patient.
General information. The patient's name is Eric John D. Laxamana, living at 3rd Paroc 2 San Antonio Arayat, Pampanga, born on September 24, 1990. He's a male with a height of 1.75 meters, weighing 51 kilograms. Religion is Catholic and nationality is Filipino. Eric's chief complaint is, may basag ako ng ngipin na nangingitim na sa may bagang. His history of present illness is, prior to consultation, the patient feels sensitivity whenever it is hit by a toothpick, and the duration of sensitivity lasts for 2 seconds upon removal of the stimulus. Upon his medical history, he has a good growth and development, cardiovascular system, respiratory system, good genitourinary system, good endocrine system, good hematopoietic and lymphatic system, gastrointestinal system is also good, and he doesn't have allergy. But under the central nervous system, it is noted that he had a fainting or loss of consciousness before because of a head injury, but there are no any sensory disorders. And also under the skin, he has a history of skin problems, which is boils or the pigsa, but he doesn't have any history of cold sores or canker. And for the extremities, he experiences joint problems such as arthritis, but he doesn't have any problems with muscle weakness or muscular dystrophy. The overall general health of the patient is good. He has been hospitalized before at JBL Hospital last June 11, 2014 because of vehicular accident with head injury and minor scratches. For immunizations, you only have immunization for polio. Then for illness, he experienced chickenpox before, tonsillitis, and sometimes he experiences common colds. Dental history. He experiences toothache or immediate dental problem. He experiences discomfort when brushing his teeth, bleeding gums when brushing his teeth or sometimes chewing. His gums are swelling and there are food impactions, and he had difficulty opening his mouth when he has colds. Upon clinical examination, extraoral examination, his head shows to be normal, eyes is normal, TMJ is normal, his vital signs, which includes the blood pressure, pulse rate, respiratory rate, and temperature rate, is in normal range. Clinical examination for the intraoral, his lips is normal, palate is normal, floor of the mouth appeared to be normal, tongue is normal, and the gingiva is somehow inflamed.
Here we have a radiographic analysis of the patient. So it appears that the patient has horizontal bone resorption on most of the teeth except for tooth number 26. The periodontal space is present in all, alongside the lamina dura. There was calcular deposits present in only tooth number 23. A sinus approximation mostly absent but present in the molars, mainly the upper, and one lesion was found from tooth number 23 to 25, and no furcation involvement. And last but not least, our diagnostic.